Good morning. And we like to welcome you all to our first Pink Out, standing in the gap for breast cancer survivors, ones that have passed on. We are standing, we acknowledging today that they're not in this fight alone. We're here with them. Whether it be prayer or we need someone to talk to, others that have been there can share their testimony with somebody that's going through. We as women have to first get our mammogram, and then second, we have to open up and talk to somebody else so you won't be in this race alone. Because one thing that I know, because I have had family members that have walked this walk and are still survivors, thank God. But we prayed, we talked, we cried, we laughed, and people need that. So with that being said, we just want to say welcome you to our first annual Peak Out in honor of breast cancer. I get so nervous. I'm having this. Don't be nervous in front of babe, I be nervous in front of my daughter. They can hold it. So much more people now. Gotta adjust. All right. I got it. Come in tonight. There we go. 1, 2, 3. 1, 2, 3. 1, 2, 3. And one more for good look. Okay. Thank y'all. All right. Gotta play back. Thank okay. You. Lord, mercy. Anybody have their purse with them this morning? Okay. Sure. I don't need money. Yeah. Okay. Okay. Y'all don't have y'all purse? Huh? Okay. So, Oza was the first person to sign in, so she gets a $20 gift card, a cup holder from Starbucks Nutrition. $20
McAllister's. It's over there. Why are you giving it away? They sell more than that. They sell loaded teas. Right. Right. So we gonna play what's in your purse. Our speaker is not scheduled to be here until he said he's gonna make it about 10:30. So we're gonna play what's in your purse. I need a pen. Yeah. Oh, give me a pen out your purse. I know you. Okay, I got one of those. Okay, so the first, what's in your purse? I know everybody got these keys. Everybody got keys. Everybody got keys. Lip gloss. Everybody got lip gloss. Yeah. I thought everybody was back in. I'm sorry. Keys. Keys and lip gloss. All right, fine. Okay, keys and lip gloss. Y'all ready for the next one? Phone. Yeah, credit card. Candy. Yeah. Yeah. Sunglasses. Sunglasses. Everybody got sunglasses. Receipt. I know I have plenty of my purse. Tissue. Okay. Now I'm finna see who got this in their purse. Library card. Miss Tate. Miss Tate, Oldie, and Oldie. Okay. So whoever got this in their purse go get the gift. A sewing kit. I mean, you know, folks used to take them in their purse all the time. Little needle and thread. Nobody with needle and thread. They do. They do. Floss. Anybody else got floss? Nope. You got floss? Okay. Nail polish. Ain't nobody got nail polish. I mean, different stroke for different folks. There's a lot of folks in there got their nail polish. Pepper spray. Right here. You got pepper spray? Oh, whatever. No. Nobody has pepper spray. A USB drive. Keela got one too. Her two and twin. Okay. So foreign currency. I know y'all got a Canadian penny. Nobody? I said, who? You show it to me. Nobody? I ain't even got one of them in my purse. Oh, well, the twin come back with this foreign currency, she gonna get a gift. What's that guy? Everybody, the morning you had it, got to be a gift that's something in your purse that nobody else has. Got it? I don't want it. She got foreign currency. So, thank you, Shania. You don't want it? Oh. $20 gift card to Wendy's. Okay. So the next thing on the program is a speaker, but we're gonna skip over him and go to Gia, and she is Why We Wear Pink.
The story behind the pink ribbon. That pink ribbon that seems to wrap around our planet each October is widely seen as the official symbol of breast cancer, at least of the female variety. It's highly recognizable and carries a strong physiological tug and is most often associated with Susan G. Komen group. But that isn't exactly where it started. So here then is the story and the true link to the pink. Charlotte Haley, who had battled breast cancer, introduced the concept of a peach-colored breast cancer awareness ribbon in the early 1900s. The 68-year-old Haley began making peach ribbons by hand in her home. Her daughter, sister, and grandmother had breast cancer. She distributed thousands of ribbons at supermarkets with cards that read, "The National Cancer Institute annual budget is $1.8 billion. Only 5% goes for cancer prevention. Help us wake up our legislators and America by wearing this ribbon." As the word spread, executives from Estee Lauder and Self magazine asked Haley for permission to use her ribbon. Haley refused, saying the companies were too commercial, but Self magazine really wanted to have her ribbon. The magazine consulted its lawyers and was advised to come up with another color. It chose pink, a color that focus groups say is soothing, comforting, and healing, a far cry from what breast cancer really is. Soon, Charlotte Haley's grassroots peach ribbon was a history, and her original idea became the pink ribbon that has come to be known as the worldwide symbol for breast cancer. The breast cancer movement is much bigger than October, and it's only about finding a cure or getting a mammogram or and it isn't only about finding a cure or getting a mammogram or raising money. It's about prevention and education and guaranteed treatment for everyone, women and men, rich or poor. It's a crusade that should unite all of us at every level. That pink ribbon, after all, is just the pretty tie that sits atop a box in which the gift of life has been wrapped, and where the hope of a cure has been waiting to be released, to become the perfect gift for each of us who knows cancer all too well.
And so now, it is the person that has the most festive pink attire. I told y'all to wear y'all festive pink. Cool. Okay. Who all vote Crystal with the most festive pink? All right, Kai. Okay. So until he show up. So it's gonna be passed the gift. So this gift was donated by Shonda McGee, and she does her business. Shonda is okay. It's McGee's Tea, and she donated this. Really, shout out to all my people that um. So okay, so it's past the gift. I guess it's you. No, no, no. Okay. So the first question is, have you ever gone for more than 3 days without taking a bath? No. So, no, it's just a question. But you don't have the gift, so it's for the person that has the gift. So, so if the answer, what's the answer? Is it yes or no? No, it's only for the person that has the gift at the time. And you see, I don't know that answer ain't gonna cut it. Okay, well, pass the gift to twin. Okay, so the next question is, have you ever gotten sick after riding an amusement ride? Okay, well, you keep the gift. We're going to go to another gift. You keep the gift. Your answer was yes. So if your answer is yes, no, you don't pass it. It's your gift. Okay, yeah, I need another gift. I thought we were going to go faster than that. Mm-hmm. We'll just go with this one. Okay, so this gift was donated by the Ideal Shop on Main Street. It's like you can go if you like if you're crafty, you can go there and they'll allow you to do like create your own designs for free in their shop. Like this is a charcuterie board that one of the students from Mississippi State made, and you can like make all kind of designs and put on stuff just for somebody that likes to craft or create things. Okay, so the next question is, you take the gift first. Okay, so the question is, have you ever regifted a present you received? Okay. Wow. Don't y'all get her no gift. Next gift. Mary Kay. These gifts from Mary Kay was donated by Andrea Ewing. She's a Mary Kay consultant. And she does a lot of things. She has little balloon things that she do. A lot of little stuff. Having an event like a carnival, she does like stuff like that as well. So so the question is, do you squeeze your toothpaste in the middle? Well, you the gift. Yeah, cause like some people squeeze their yeah, me too. Janae, now we talking about Janae. So this gift was donated from Andrea as well, and so you can give this gift to Miss Renee. So oh man. So this question is, do you fold your underwear? I know, right? She said, I know, I do too. Okay, so this gift was donated by Andrea as well, and you could give it to Jamie. Next person on the oh no. So this question is, do you always put makeup on before leaving the house? Okay, moving right along. Okay, so the next question is, do you cook only using recipes? So the next question is, do you shave your legs in the wintertime? Okay, so honestly, honestly. So the next question is, are you up by 6 a.m.? Okay, so the next gift was donated by Raquel Orr. She has She Rose Designs. She makes t-shirts. And give it to the next person. Give it to me, Mary. She on the same row again. So the question is, do you have to have your coffee in the morning? Do you have to have your coffee in the morning? Okay. You can pass. Okay, so have you ever smuggled snacks into a movie theater? Okay, so this gift bag was donated by Jessica and Jessica Akins, and her business is Royal Crafts and Creations. So I'm telling y'all this so y'all can patronize these people. But she do designs and she also makes candles too. So, just so you know, it's about to be Christmas time. Oh, the that was a gift Kai got. Yeah, Oza, she got something there. Okay, so the next question is, have you ever double dipped at a party? Okay, so the next question is, do you get your nails done professionally? Get it. Okay, so have you ever taken a mission trip? Do you ever tell phone solicitors you are not at home? Okay. Do you think you should stop now and enjoy a piece of mint? The question is, do you think you should stop right now and enjoy a mint? So, have you ever worn something and taken it back? You keep it. You don't have to take that one back. You can keep it. Now I'm waiting till she get finished. Okay, so this gift was donated by Raquel Orr as well. C Rose Designs is her business. make your bed every morning? All right. Yeah, 'cause it's like right now it's too hot. That's what's up. So she keep the gift. Huh? Well, don't ask me. Yeah, it's separate. But it's some whatchamacall. It's some whatchamacall that go with them. Some little compact mirrors. Yeah. White line. Oh no, I'm gonna get into the we probably should have walked longer. Mhm. Um. Okay, so this candle, it's a candle, and it was donated by Hallmark. So this candle goes to who's the next person? Okay. So the next question is, do you recycle your grocery bag? Okay. So the next gift is this mug, and it was also donated by Raquel or the C Rose Designs. I'm put it back in the box. And she did this like she does these things like they don't want no mug. Okay, so the last question is, it say, do you hide your own treats? Okay, so that's the last question. Okay, so check this. Somebody got a number in their bag. Somebody has a number in their bag. Somebody has a number in their bag. It's folded up. This shirt was donated by Sequoia Sherman, and her big bully balloon store. And these bags and compact mirrors donated by Shama. Okay, so running out of It's a large. You can wear it. No, I'm saying I don't want her to have something that she can't use. Moving right along, Keela. Okay, so here you. It's okay, it don't matter. Sure. So the other game, it's kind of, I guess we could have went to the back. It's kind of like a game you have to do at the table. But I was hoping one of the two would have shown up by now. Yeah, one of the two. Yeah. We should have stayed down the road a little longer. Okay, twin, give me a number. 1 and 20. So these are some earrings. Janika Gandy, she makes these. Got the number? Don't tell me. Okay, somebody guess the number. When you get it right, somebody gonna get some earrings. It's between 1 and 20. Okay. Another pair of earrings. Got the number? All right. When you get the number 20. 1 and 20. 1 and 20. No, it was not. It was 2. Look, so we're not playing lottery. We're giving away this. They don't have to buy anything. No. We're not playing. We're not calling numbers right now. So look, because we have 2 survivors in the room, I'm gonna give both of one each. Miss Renee and Miss Renee and Miss Lois. Miss Lois. Okay. Miss, you don't got no game. So. What up? Did I take the papers from that was right here? I did. I don't know. I didn't know if I had picked them up or not. Okay. So while he's doing that, I'm just gonna go ahead and tell y'all who he is. His name is Chip Wall. He is a fellowship trained surgical breast oncologist and limits his practice to the treatment of breast disorders, both benign, malignant, and benign. He is a member of the American Society of Breast Surgeons and is certified by the society in breast ultrasound and stereotactic breast biopsy. He is a fellow of the American College of Surgeons and certified by the American Board of Surgery. So, Dr. Chip Walls.
For having me. I appreciate Lenore for the invitation and for the opportunity to speak here today. I'm going to have to kind of change this a little bit just so I can see the slides. I kind of go off the slides that I use. But so it's October. Obviously, y'all are ahead of the game and early in the month getting the breast cancer awareness event going. But I've given this talk a few times before, and it's just kind of a general overview of kind of the nuts and bolts of breast cancer, and it's to talk about the basis of breast cancer and screening and some other things you can do for preventive care. So with that, we'll just get started. We'll have the first slide, please. Okay. Okay. So, you know, I'm sure you know this, but about 12% of women in the United States have breast cancer. That's 1 in 8. And so for those who may not be affected by breast cancer personally, you may know someone who has the diagnosis. It doesn't take too large of or too small of a friend group, and then next thing you know, you're dealing with friends, relatives, and affected by breast cancer. Okay, next slide. So among the 3 most common cancers in women, breast cancer first. Actually, skin cancer is first. That's across the board. But taking skin cancer out, breast cancer is the most common cancer diagnosed in women. And in terms of leading causes of death, it's second only to lung cancer. So obviously, it's a very important malignancy. There's a lot of focus on research and treatment for breast cancer. We've made strides over the years, and we'll talk a little bit about that, but it's a very common. Next slide. So in 2024, there were 310,720 new cases of invasive breast cancer. This is up from 297,000 the year prior. And in terms of the non-invasive type of breast cancer, or what we call carcinoma in situ or ductal carcinoma in situ, DCIS, there were 56,500 new cases in 24, and that's up a little bit from 23. And again, 1 in 8 women, about 12 points affected. So I know these numbers, there's no need to worry about that, but the point here is just the trend going up. And so, next slide. Ductal carcinoma, we see that about 10 to 50, or 20 to 25% of breast cancer is diagnosed, and that is the non-invasive type. Typically, it's not something that you can feel, and it's only something that can be detected usually with mammography. Usually little microcalcifications that tip us off. There's an abnormal area, and then we'll go from there doing a needle biopsy. But the cells are confined to the duct. There's no invasion to the wall of the duct, and it can be low, intermediate, or high grade. Next slide. So in terms of breast cancer mortality, here's the good news. Since 1989, the overall incidence of death from breast cancer has decreased by 44%. So that's a significant thing. That's something that we should be very proud of and continue to work harder to get that number to go even higher. And we think the reasons for that is advances in early detection. So, you know, since 1989, that's been, 35 years. And so we have better mammography and MRI and also contrast-enhanced mammography. So for sure, advances in early detection, but also advances in treatment. A good example of that is HER2-positive breast cancer, which used to be what I would kind of refer to as a bad actor. But because of the chemoimmunotherapy that we have for HER2-positive breast cancer, it doesn't have the impact that it used to have. Now here's kind of the downside of that. So we know that the survival is going up, the incidence of mortality is going down, but new diagnoses are increasing. We see an increase of about 1% per year in the interval between 2012 and 2021. And of the women, if you look at the specific category of younger women or women under the age of 50, that is approximately a 1.4% increase per year. So we're seeing an increase in the incidence of breast cancer diagnosed in younger women. And the reasons, they're multifaceted, they're complex, but some postulations are increase in obesity, women who are having delayed childbearing, they're having children, if they have children later in life. Environmental toxins possibly are playing a role. And then even it was mentioned that delayed diagnosis due to the pandemic. But this is an increase in the incidence of breast cancer, not just in the United States, not just in developed Western countries, but this is a global increase. So that's something that epidemiologists are looking at, but we just don't have all the answers yet. But the trend is established and real and something that we need to be aware of. I mentioned ductal carcinoma. The more common subtype of breast cancer is the invasive ductal carcinoma. That's about 25 to 80% of all breast cancers. This is where you have abnormal cells invading through the wall of the duct in the breast tissue. And so because of that, it has the potential to metastasize. And typically it's to the lymph nodes in the underarm area on that side, and then potentially to distant sites like the lung, the liver, bone, brain. Okay, next slide. So this is just a picture of kind of the progression of what happens in a very simplified version of what happens when a breast cancer develops. You can see you can start on the left side with just a normal duct. And then you can have what we call ductal hyperplasia. That's where you just get some overgrowth of cells in the duct. And then some of those overgrowth of cells turn into abnormal cells or atypical cells. Next thing you know, it's ductal carcinoma in situ, which is breast cancer confined to the duct. And then you see the depiction of the invasive ductal carcinoma, where the abnormal cells, the malignant cells, invade through the wall of the duct. Okay, next slide. So risk factors. So major risk factors, obviously being female, but breast cancer is something that we see in men, but it's only about 1% of men. So obviously, the far majority are in women. Increasing age. This is typically a disease of older women, but like I said earlier, we're starting to see the incidence increase in younger women, women under the age of 50. If you have a family history of breast cancer, if you have a blood relative, mother, sister, grandmother with breast cancer, that increases your risk. If you have a diagnosis of atypical cells, atypical hyperplasia, or ductal hyperplasia, or lobular carcinoma in situ, these atypical findings, but they're not malignancy, that's an increase for breast cancer. And then gene mutations. About 3 to 7% of women who have breast cancer have genetic mutations. So that means about 90 to 93% of women who have breast cancer do not have a genetic mutation. But if we always check for gene mutations, because that's a significant thing. For instance, a BRCA1 mutation, if you have that abnormal gene, it increases your risk of breast cancer at about 87% over your lifetime. So if you look at the average risk of about 12%, for a woman who has a BRCA1 mutation, the risk is about 87%. So in the women that we can find that out before there's a diagnosis, and we can take preventive measures, either enhanced surveillance or preventive surgery, that's the goal there. Even women with BRCA mutations respond better to different types of chemotherapy, so we like to know that information going in. Minor risk factors, what we call early menarche, or if you start your, women who start their period before the age of 12, or if you have menopause come on after age 55. So really it's that period of time where hormones are active in the premenopausal period that puts you at risk. It's all those hormones that we think increases your risk some. So if you start that earlier, or if it goes on later before it ends, that's a minor risk factor. Nulliparity, or not having children, is a risk factor. If you have a child after the age of 30, we talked about in that slide earlier about women who have delayed child rearing or childbearing. This is an example. This just goes along with that. If your first child is not until 30 or older. Estrogen replacement therapy. You see a question mark beside that. Actually, for postmenopausal women, your period has stopped. For those women who are on estrogen alone, that's actually a protective benefit or protective factor by giving estrogen, but you can't take estrogen alone if you still have your uterus. So for the postmenopausal woman who's had a hysterectomy, that's a good candidate if she needs it to take estrogen replacement therapy and not be at increased risk for breast cancer. But we can't give estrogen and progesterone together if you still have your uterus and it not be a risk factor. So that's the combination we try to stay away from. Daily alcohol intake, and then as we talked about dietary fat, which leads to obesity, that's a risk factor. So protective risk factors are breastfeeding. We know that reduces the risk of breast cancer, exercise, and then childbirth before the age of 30. Okay, next slide. So this is basically the same thing, but I just want to differentiate between those that we can't change and then those that we can. So the non-modifiable, obviously, is your gender. If you're female, your age, you can't change that. If you have a genetic mutation that's in your family, you have no control over that. Dense breast tissue, which is a risk factor, that's something you can't change. But the modifiable risk factors are something that we can focus on and consider in risk reduction. And so not having children is a slight increased risk. Oral contraceptives, slight risk. Hormone therapy, we talked about, if it's estrogen and progesterone together, that's a risk factor. Breastfeeding reduces the risk of breast cancer. Alcohol increases your risk. Obesity increases your risk. And physical exercise is a risk reduction benefit. Okay. Next slide. So, you know, not every breast cancer reads a textbook, but here are just some things that you need to look for. And if you noticed, you might want to see your primary care physician or see someone like me just to check it out. We do a lot of checking out lumps and bumps, and the far majority are benign or they're just breast tissue. But it's always good to check and have that reassurance and confirm that it isn't an issue, because the flip side of that coin is things that are neglected, and the longer they're neglected, the prognosis is worse. So if you notice a painless lump, nipple discharge or nipple or bleeding from the nipple, if you notice any change in the shape or the contour of the breast, or pain in a region of the breast, if you see any dimpling of the skin or discoloration of the breast. I just saw this past week. She didn't even notice that she had some changes of her skin, but she felt a little lump, and sure enough, she had both dimpling, a little divot in the skin, and then there was a little bit darker in that area. If you notice any distortion of the nipple, if it's pulled in any direction or pulled in, that's a concern. And then if you feel any lymphadenopathy or a lump in the underarm area, that would be something that you want to get checked out as well. Okay, next slide. So just across the board, we can talk about the differing opinions on when to begin screening mammography, but just remember that at the age of 40 is when you need to start your yearly mammogram. We can start it before, but we typically don't unless there is a reason to start it before. So mammogram beginning at age 40 and then every year thereafter. Not every other year, not every 5 years. It's every year thereafter. For women who are 20 to 30 years of age, they need to have a clinical breast exam about every 3 years. If you're 40 years and older, your primary care doctor or your OBGYN or someone at the breast center needs to be doing a breast exam, a clinical breast exam every year. A self-breast exam, if you're 20 years or older, needs to be, that means checking yourself in the shower or monthly, doing a self-check every month. I mentioned earlier magnetic resonance imaging, or MRI. We do MRI of the breast, and it's actually the most sensitive imaging study we have for the breast. It's not the most specific. So what that means is it picks up everything, and even stuff that's not even any concern, and we typically have to kind of run those down and check them out. But it does, because of its high sensitivity, it's good for identifying issues that are smaller or in women with dense breast tissue that we otherwise wouldn't be able to see with mammography or ultrasound. And then genetic counseling. Again, not every woman meets the criteria. Anybody can have genetic testing, but do you meet the criteria to have it paid for by insurance? That's kind of the difference there. Anybody can have it, but not every woman meets the criteria for that. Next slide. This is, we don't have to read all the fine print here, but this is the American Society of Breast Surgeons, their position statement on screening mammography. Let me just summarize for you. Beginning at age 40 and every year after. Next slide. The American College of Gynecology, beginning at age 40 and every year after. Let's see. What the problem is here is this United States Preventive Services Task Force. They have recently changed, thankfully, but the last time I gave this talk at an event last October, they had not changed yet. But because of this data which has come out on more diagnosis in younger women, they have changed the confusing guidelines to beginning at age 40. So next slide, please. But the point is, American Society of Breast Surgeons, American College of Radiology, American College of Gynecology, American College of Surgeons, everybody recommends beginning screening mammography at age 40, and then every year thereafter. And now the USPSTF has fallen in line because of the new data that's come out, so should be no contradictions. But if your primary care provider gives you any trouble about you only need one every other year or every 5 years until you're 50 or anything like that, the data shows that you need a mammogram beginning at age 40 and every year thereafter. And for some women who are in the higher risk category, we begin surveillance or some type of screening before that. Next slide, please. Okay, I think we've kind of touched on that. We know that screening mammography improves your survival even for younger women ages 40 to 49. If you're diagnosed in early stage, you're more likely to be a candidate for what we call BCT or breast conserving therapy. That means a lumpectomy versus a removal of the entire breast. You're less likely to require chemotherapy, and you have improved survival compared to women diagnosed at later stages. That makes sense, but that's what we know from data. This is all data driven. Next slide, please. So I just put this up here to show you kind of in contrast how much radiation you're getting with the mammogram compared to other things you may be aware of. So if you see at the bottom, mammography is 0.4 millisieverts. And then for like a chest x-ray, it is 0.1. So you do get a little more radiation, but it's a lot less than you get if you have a PET CT scan or CAT scan, which people get these all the time. So just want you to know that you're not getting much radiation from mammography. Even our new 3D mammography or tomosynthesis, where we actually take a few more images, there's a little bit more radiation, but it's not something that you should be concerned about, a dose of radiation. We don't like to give mammograms to 20-year-olds for these, just like we like to get multiple chest x-rays on a 20-year-old, but it's appropriate to get a screening mammogram at age 40 and every year thereafter. Okay, next slide. So I think this is something that I hope you'll kind of make an imprint on your brain. Stage 0 is DCIS, or the non-invasive type of breast cancer. Your survival, if you're diagnosed with stage 0 breast cancer, is 100%. So if we look at women 5 years out from treatment, diagnosis and treatment, their survival is 100%. Same for stage 1. So that stage 1 is invasive breast cancer that's less than 2 centimeters and node negative, 100%. Even if you go to stage 2, which means a little bit larger tumor and or lymph node involvement with today's current treatment, if you have the standard of care, current therapy, your survival is 93%. But then you see when you start getting into stage 3, stage 4 means there's distant metastasis. And that's where the breast cancer has spread via the lymphatics of the blood system to the liver, the bone, the lungs, the brain. Obviously, the survival decreases the later stage. And so this is just a graph form. You can see how well women do their early stage and how that drops off as the stage increases. Okay, next slide. So this is something I want to touch on just because for those of you who are getting mammograms, you may be getting in your report, because it's required by law that we notify you if you have dense breast tissue. So I just want to talk about that for a second. Breast density changes over time, and it's different for different women. Typically, if you were to image a 19-year-old, they would have very dense fibrous tissue. That's why a 19-year-old's breast looks very different from a 69-year-old woman's breast. But the categories are class A or class 1, which is fatty replace. That's really no fibrous elements in the breast tissue. It's all pretty much fatty tissue. about 10% of women have completely fatty replaced breast. At the other end of the extreme is what we call extremely dense. That's where you have pretty much fibrous, dense breast tissue throughout the entire breast, and there's about 10% of women in that category. The two middle categories, the scattered fibroglandular, which is B, and the heterogeneously dense, C, those are each 40%. So 10, 40, 40, and 10. That means about half of women do not have dense breast tissue, but about half do. So for those women who are getting a mammogram report that it shows dense breast tissue, more than likely you're going to be in that class C with a lot of other women. But that's not a bad thing. The risk does come in for the woman with the extremely dense breast tissue. That in itself is a risk factor. Okay, next slide. This is just what I was kind of saying. The more glandular ducts and lobules and supportive stromal tissue, it increases the density, and it can be inherited. I mean, typically a younger woman has dense breast tissue, and that becomes more fatty replaced as we age, but we have patients who even in advanced age have just very dense breast tissue, and that's probably something familial. It's just inherited. There's about a 4-fold increased risk of developing breast cancer for women with extremely dense breast tissue, and that's just because of the breast tissue itself, but also probably a little bit because it's harder to screen or image women with dense breast tissue. Okay, next slide. So this is a tumor in someone with a fatty breast, that little tiny dot, and that's hard enough to pick up on just someone with a fatty replaced breast in mammography, but you can imagine trying to see that with dense breast tissue. So we typically perform risk calculations, and depending on your family history and your dense breast tissue, we may do some type of enhanced screening like MRI or ultrasound for women who are in that category. Next slide. So if your calculated risk is over 15%, you're qualified for an MRI, 3D mammography, which we have, and we've had since 2018. That increases our detection rate and decreases your callback rate. And then in terms of lifestyle choices, again, maintaining a healthy weight, regular exercise, eating healthy, and not smoking all reduce your risks. Okay, next slide. So, I've just touched on high-risk screening just a little bit, but if you look at the incidence of breast cancer, about 70 to 80% are just sporadic. We don't know exactly what causes them. About 15 to 20% are just familial, meaning you may have a family history of multiple people diagnosed in your family, but you don't have a genetic mutation. Then there's that 5 to 10%, 3 to 7%, depending on what you read, of women who have an inherited genetic mutation. And the way I kind of describe it is these specific genes that we've identified that are related to breast cancer, primarily BRCA1, BRCA2, these are protective genes, and when they are defective, when they're not functioning, you lose that protective benefit. Next slide. This is just an example of risk calculations that we do. You enter data from your age of starting your period to how many pregnancies you've had, your pre or postmenopausal, any prior breast biopsies. A lot of factors go into the questionnaire, and then the computer spits out these numbers, and there are actually 5 different risk models here that give us a 5-year risk and a lifetime risk, and depending on what those numbers are, then that helps us helps guide what kind of screening we do, whether it's just normal screening or enhanced screening. Next slide. I think this is just kind of repeating everything I've said, but for women who have a lifetime risk of breast cancer of over 20%, if they have a known gene mutation, if they have a first-degree relative with breast cancer, if they've had radiation therapy to the chest wall, like to treat maybe a lymphoma at an earlier age, that's a risk factor. And then these certain genetic mutations put you at an increased risk. But all that goes into that risk calculation and gives us a number. That based on that, it guides our screening. Next slide. This is just a slide to show you these different genes that we know in some way are related to increasing risk for breast cancer. So this is, I don't know how many, maybe about 10 up here. The panel testing we do now has about 30 on it. Not all of them are related to breast cancer. So the panel test that we do at the Breast Center at OCH tests for these primary 10 breast cancer-related genes, but also other genes like colon cancer, pancreatic cancer. So we kind of cover the waterfront with our panel testing that we do. Next slide. So I'm sure at least some of you know Dana Brooks. She's lived in Starkville most of her adult life, and she's a nurse practitioner at the Breast Center, and she's great. She does a lot of our high-risk screening. So either one of us would see you if you had a question about a breast issue, or if you want to be evaluated for elevated risk based on family history, those kinds of things. So I think that's about all I have. Thank you. You know, let me say this if I can, because one concern about the increased incidence of younger women being diagnosed with breast cancer is access to screening. And we have a very busy, breast center that sees probably over 500 or does over 500 mammograms a month. We've got another mammogram machine coming. But we're averaging now about 80 no-shows per month. And so that means that women who have been called and confirmed for their appointment don't show up for their appointment. And we've done all kinds of things. You just can't make people come in, even with a phone call or a reminder text, those kinds of things. But you can imagine how 80 no-shows a month, that kind of accumulates month after month. So that means that someone who could be using that slot, because we weren't notified or someone didn't show up for it, that's a missed slot for another person. So our wait list, it just gets longer and longer every month because we're averaging 80 per month. So I just say that to let you know that women are calling and they're wanting a mammogram, a screening mammogram, and they're told, oh, and we can't see you until February of 25, and that's very concerning to people. It's very concerning to us, but we're doing everything we can. I think the new mammogram machine that we're adding is going to help for sure, but it's this average of 80 per month that's really kind of hurting us, and so. I'm trying to let everybody know. Not that anyone here is doing that, but like in talking with your friends or whatever, if they mention their mammogram, so be sure and show up for that, because that's the important thing, because if you're not taking that slot, you're taking it away from somebody else. And that's just kind of how we have to think about it. But that's just my little plug at the end. But if there's any questions about anything I said, I'm happy to take some now. Yeah. Mm-hmm. Yeah. No. So someone with a genetic mutation, we want to know about that. We're not just going to, hey, we'll see you at 40. No, it's going to be typically an MRI beginning at age 25, because there's no radiation with MRI. We feel like we can do that and get a good, obviously, the most sensitive imaging study we have for a woman and looking at their breasts. that begins at age 25. We don't start screening mammography until age 30. So we do it earlier for women at high risk, like for genetic mutation. That's what we like to know about it. But typically, we don't start checking for genetic mutations until you're 18. So if we have that's not true with everybody. I've got a particular family that there was one 16-year-old who was very mature and wanted to know then, and so, you know, after we kind of talked about everything, she had testing, and sure enough, she's positive. But she was mature enough to handle that information, and she liked to know the information because she can make a plan going forward. Typically, for a young woman that we know has a genetic mutation, who's not even gone to college yet, or certainly not gotten married and had a family, it doesn't mean that you can have all those things, but we just watch you very closely. And typically, after marriage, if that's what you decide to do, and children, if that's what you decide to do, about age 35 or beyond is when we start talking about, for like if someone with the BRCA1 mutation, about preventive surgery. So, any other questions? Oh, no, that's a great question. We absolutely want to see prior mammograms to compare those with your latest mammogram. And so, and that happens a lot. Obviously, people, especially in a college town, people move in and out a good bit, but we definitely want your prior mammograms for review. If there's a spot that's been there, but it's been there for 10 years, we like to know that, because that, you know, lowers our level of concern for that area that we're seeing for the first time. But then, and when you review the prior imaging, it's been there for 10 years. So, you know, typically that's not something we're too concerned about. But that's a great question. And that's not hard to do. Either putting it on a disc, or nowadays we're starting to do something, at least with OCH, called PowerShare, which is electronically sending images over. Now, not everybody's set up to do that, but we're starting to do that more and more, where we're sharing images electronically. You don't even need to take a disc with you. But great question. Anything else? Yes, ma'am. Another great question, and that's a hard one. The recommendation is if a woman's life expectancy is 5 to 10 years or less, then she can stop mammography, which is a really hard discussion to have with somebody. And I personally don't do that. I think there is chronologic age, and then there's physiologic age. There are some very old and unhealthy 60-year-olds, and conversely, there are some very healthy and youthful 80-year-olds. And so I think it's an individual decision, but I don't have a set number. If I see, for instance, my grandmother lived to be 100 years old. If she would have stopped at 80, that would have been a 20-year period of no surveillance. And so it's really an individualized thing. But the textbook says lifespan or life expectancy less than 5 to 10 years. But again, that's just kind of a hard discussion to have with somebody. So I encourage just to keep on going, because, you know, I've had multiple cases of older women who stopped screening mammograms come in with a large lump, and then we start the process, you know. Yeah, yeah. So, let me just answer that with an anecdote, a clinical example, because this happened in the past 2 weeks. A nursing, well, not a nursing home patient, but actually lives at home, and is in a wheelchair, multiple medical issues. You know, it's not like she's got some vibrant, active lifestyle. She pretty much stays in a wheelchair and has a lot of medical issues going on. A large lump was found, I think, in bathing, and so we did a biopsy, and sure enough, it's, you know, as expected, of breast cancer, but fortunately, it's one that's responsive to a pill that you can take. It's hormone receptor positive, and so I've got multiple patients who are not physically or medically fit to go through chemotherapy or surgery or both, and so we put them on anti-hormonal therapy, and typically to date we've had very good success. Not just me, but like it's kind of the standard for women who can't have the conventional, normal, standard treatments to do something like that. But not every woman has ER, PR positive, or estrogen receptor, progesterone receptor positive breast cancers that respond to that. So I guess some of the thinking with some of these nursing home patients is their life expectancy is less than 5 to 10 years, maybe. And so whoever the provider is for that facility or their personal provider just has stopped certain screening things, which is not an unreasonable thing to do. But again, when it's discovered, it needs to be addressed. Right. The short answer is no, but that kind of goes back to risk factors and the family history and that kind of thing. And if you have a calculated risk score, then we talk about the enhanced surveillance mode, which is not only your yearly mammogram, but maybe a breast MRI, and we alternate those depending on what your risk is. But you're right. The incidence of breast cancer in African American women is higher, but it's not as high as Caucasian women. It's actually higher for Caucasian women, but it is high in the African American population. And one reason we think is because of the incidence of triple negative breast cancers. Which is one of the more difficult ones to treat, and the incidence of early recurrence and distant disease is higher. So the triple negative is a little bit harder to treat, and that's higher in the African American population. So, does that answer your question? Yes. Yeah. We don't say, oh, this person is an Asian Pacific Islander, so we're going to do something different for them, versus a Caucasian woman or an African American woman or a Native American woman. It's all the same, but what changes is your personal individual risk score in terms of changing your screening schedule. Well, Several things go into that. Stage 4 is what we call distant metastasis, where it's involving other organs. We typically don't operate for that. But in the other 4 stages, 0 through 3, it all goes into the age of the patient, the size of the tumor in relation to their breast volume, whether or not it's what we call multifocal or multicentric, meaning if there's more than one tumor in the breast, that makes it more difficult to conserve the breast. But the majority of breast cases, if you look at national numbers, most women, about 2/3, have breast conserving therapy, meaning they go the route of a lumpectomy, they save the breast, and the other 1/3 have removal of the entire breast. And so a lot of factors go into that, and one of the largest is just the individual's preference. But it is by far, the breast conserving therapy is the mainstay of what we do, is lumpectomy. If a woman with a larger breast had a 2-centimeter tumor, that would be fairly easily removed with a lumpectomy. If a very petite, smaller woman had the same size tumor but in a much smaller breast, it might be harder to get that tumor out with clear margins and not leave some defect in the breast that just cosmetically wouldn't be acceptable. So, but I will say that, breast conservation is a package deal. I've said this before a lot of times, but it's a lumpectomy and radiation combined. Typically, that's the standard of care. And for mastectomy, it's typically, because we're essentially removing all the breast tissue, you don't need radiation therapy for that. Now, there are indications for what we call post-mastectomy radiation therapy, but that's usually for larger tumors involving the chest wall, nodal involvement, those kinds of things. So. I think I'm infringing on someone else's time, and you're going to enjoy her much more than me, I can assure you. Thank you all for having me. Lenora, thank you. I appreciate it.
Okay, so we're not gonna prolong the time. We're gonna let First Lady Jones come up and do her thing. All right, so, introduce myself real quick. I'm Jessica Jones. I have been, okay, I've been married for 19 years. So my amazing husband, Pastor Peter Strife, so his name is Michael Jones. I have 2 amazing children that are on my feet. They are 17, and about. Let me just dive in. I get so amazing. My doctor back there, that's my amazing doctor. I got diagnosed so unexpected in 2022. But here I am today, cancer-free. I kind of want to just share that my story, I would say, started out, like I said, unexpected. I had a friend that was going through during chemo and everything, got diagnosed the month before me, so I was encouraging her and motivating her and telling her it's going to be okay. And then, lo and behold, 2 months later, I was diagnosed, right? And I was at the point right before that, though. I was at the point of asking God. I was 39 years old. I was at the point of asking God, what in the world are we
doing here? Like, what am I doing with my life, right? And he started showing me some things about myself or whatever that I needed to let go, forgive, that I was holding on to. And then boom, cancer, right? And so I was diagnosed with 1A breast cancer. I also had to have a double mastectomy. So that was like life altering for me, right? But again, Dr. Wiles made me feel really comfortable about the decision of having to have double mastectomy. But I will also say that I tell people that breast cancer was necessary for me. So many ways. Sometimes we think that we're going through because of ourselves. It's really not necessarily about you. But it also, he uses those things to make sure that you are free and healed and things that you can see yourself in those. And so I was able to see myself in the journey of breast cancer. And so I say that because right before I got diagnosed, like I said, God, what are we doing here with my life? And I was holding on to a piece that I grew up in. I didn't think I was going to be crying today. I was holding on to unforgiveness with my parents, and I just wanted to encourage somebody, and I'm gonna sit down because I'm not gonna stay up here long. I just want to encourage somebody that when I was asking God about why is this happening, what is going on, and He was telling me that a lot of this is because of unforgiveness, and because I was holding on to my parents and didn't know, they only knew what they knew, could only do what they know to do. And so you don't realize that all of this stuff is going on. Yes, it develops in your body. It may be a lot of other things that happen in the body that causes cancer, but for me, I truly believe that it was my heart. And in that moment, I was like, okay, so what am I supposed to do with this? And the Lord was telling me that you don't really understand what real love is. And so I grew up because of this. I didn't have a lot of friendships, a lot of, how women be like, I don't believe it. That is a lie, okay? Don't let the devil set you up. But that's because of our trauma and the things that we were brought up in, the way we were brought up. And I started saying, hey, I don't really come to my house. You had a reason to come to my house. Like, and then if you came to my house and expected you probably sitting outside, right? I'm just being honest. And so, but the Lord was like, how are you a pastor? How are you in the ministry? And then you're called to them, you love encouraging them, then you can't really deal with it. Right? I had to see myself. And so he was also like, you don't really understand what real love is. And you have people that really love you. You're a loving person, but you don't understand what real love is. I'm not talking about from your spouse, children, or anything like that. I'm talking about love from me. And so I had to do some healing on myself. And I went and got some love scripture. I really started meditating on love scripture. So when I got diagnosed, people started calling me to check on me, and guess what? My traumatizing experience was to say, I'm good. Okay. Y'all need anything? Y'all good. But because I was working on myself, getting myself better, I knew the things that God had started revealing to me during this journey. When people started calling me, guess what? I was intentional. And I was like, girl, yes, you can come over. You can come, you can bring, you can come sit in my house. You can actually come and sit on my bed if you want to. And because I had to start the healing process, right? And so after that, he also told me, I hope this encourages somebody. Not only do you not know how to receive from me, or you don't really know real love, you don't know how to receive love. He said, I use in this earth to get you what so, I started experiencing love from like some of my, I have a disciple group and they were coming over, they were sitting out, we would sit outside because I was going through chemo, I did chemo for like the first part of chemo, I couldn't be around my family, I couldn't be around my children, they would walk by, they would have to wave at me in the room so that I wouldn't get sick, because COVID was very, very prominent during that time. And so I want to say all of that to say that in spite of what you're going through, that it's not always about you. And I told the Lord, I said, even in this journey, I want people to see you. I want people to experience you. So I made it my, some people, they go through and they don't want to share what's going on with them. I was very vocal, okay, about what was happening in my life because I knew that if it could only just help one more person to believe God or to believe in healing or whatever the case may be, to be free. And so my whole thing now after this experience is to just encourage women and to encourage you all to make sure you take care of yourself, make sure you are doing the proper routines, following directions, eating better, changing your diet, all of those things matter. But all of it in the core, there's a scripture that says that David said that he was holding on to so many things that it made his bones wax old. That means it makes your bones get old or whatever. I encourage you to say that whatever you're holding on to, let it go. Whoever you're still not giving, let it go. Because these people are going on about their lives, and then you're the one stuck with ailments. Right? And so I say all of that to say, there's so much, and the enemy was so, let me say just my experience. While I was going through, I was very intentional about making sure I carved out time to pray and getting my word and things like that. And the enemy would start showing me my funeral. Right? And you know how the imagination goes, it's like, who was at my funeral, who was crying, who was doing all this. And the Lord told me, he said, no, come back. Come back to what's going good right now. And I had to focus on what is going good right now. And I had to focus on, hey, I'm still alive. Hey, I'm still here with my children. I'm still able to make memories with them. I'm still able to do those things. If you follow directions, you have amazing doctor, and you're doing what they're telling you to do, and you're forgiving, and you're letting things go, it's. And so I tell people, cancer doesn't always have, cancer doesn't always have to be, right? There is hope, there is joy, there is trust, there is so much more. I just think it is advanced. Medicine, knowledge, and advanced from back when I was growing up. If you heard cancer, and you just automatically knew it was over. And but I say that to say, do the work. It takes work. It takes faith. It takes believing in God. It takes having the team of people in your life that can support you. Support me. It means everything. Support. I'm here now, and even 2 years later, I'm walking and say, hey, I was praying, and that just like melts my heart because you never know who was really, like you felt like you were by yourself, but there were people out there that really were praying. And I knew they were praying, not just saying it, but I knew they were praying. And but even my family, I talk, like I said, it's not about you. And nothing you go through is about you. I had told my family every time somebody brought some water, every time somebody brought some Gatorade, every time somebody just said, hey, I'm cashing out for you or whatever, I would go to my children and I would tell them, you know the Lord as a provider for the rest of your life. You see all this water here? It's not about mommy having cancer. It's about, do you see that all of this is the is about how can you make yourself better to be used out in. And so now I've come across some amazing ladies that are actually going through the same things I've been through, and I'm not scared to share. I'm not scared to encourage them, to let them know. Now, I had a moment now. I think Dr. Wall can attest to this. I had a moment where my smile had disappeared. And there was a moment, and I told the Lord, I said, I don't want to do this anymore. I remember, like I said, I couldn't hold my head up. I was so sick, and I slid off the side of the bed, and I was just, and I said, I don't want to do this. And I said, if this is how it's going to be with chemo, tell the doctor I'm not going back. I'm not coming back. She can have this chemo stuff, right? And my husband Marvin, he said, you gotta be strong. And I said, I'm so tired of being strong. And you ever felt like I didn't feel strong? And I remember when I slid down off the side of the bed, it was like a hand grab. And I heard the Lord say, cannot fail. Cannot I knew then. Your answer? But like I said, it took work. It took me, I would play faith scriptures, I would listen to, I didn't want no negativity around me. I had the right people in my life that would come in, pray, that would come motivate me. I had some girlfriends that couldn't be around me. We would lift the garage up, and they would have their folding chairs outside in my garage. And so you cannot tell me that everything that every person that we come encounter with, we're in our lives first. And so, as I told the Lord, I just want to say, and I would never have to go, but I want to do whatever you tell me to do. But also, this big. Do the proper work. Go to the doctor. Don't be scared. Even the phone call I got from Dr. Walls, God just set me up. That day, my friends were calling me, and they were like, let's go to dinner. And I'm like, oh my gosh, I just, didn't even think about it. And they came and picked me up, and it was like, okay, let's just go there. And so, we ate, and we got to talking, we ate at Chipotle, and then walked over to, what's the other one across the street? Not Wendy's, but Cookout. And we just sat out there and talked. And I looked down at my phone, and it was like 6 o'clock in the evening. And I said, why is Dr. Wall calling me at 6 o'clock in the evening? I didn't pick up the phone. Unusual. I didn't expect this. And immediately I was like, okay, what we gotta do? And so I got off the phone, told my friends, and we were right there on Highway 2. It was great. Everybody was coming around the restaurant, and we were just, so it's so important. I cannot stress enough. So important. Okay, no, but I'm excited about this. I'm excited to see so many women here. Breast cancer, I do come in contact with a lot of ladies now. It seems like it's just so many women in this time, compared to what I used to hear about or see or whatever. But thank y'all. You're so welcome. Good to see you.
Okay, y'all, it has really been kind of slow, but it got really good at the end, like, for real though. So I'm glad that all of you came out to share, and we're going to have lunch and play a little bingo, and then we're gonna go home if y'all want to stick around. Oh, I'm sorry. We do have a video. Like, when I tell y'all, I take my hat off to Crystal, y'all. She has done amazing. Like, behind the scenes, like, she don't never want to be recognized, but like, the girl is awesome. She's very creative. And we have a video to recognize to memorialize those that have gone on and those that survivors of cancer. So it's awesome. Like, it is so good. Like, it's so short, but it's so good. Like, she is so creative. I can't like say it enough how creative she is. But before we do that, like Miss Tony, like in the back, y'all, it's so beautiful. Like, you just go back there and it's so it's so eye catching that it's so beautiful. Like, the gifts that they have. Like, I just, I do not like not giving people their honor because they are due it. And you cannot, I can't say how much I'm so grateful to be connected to some great women. But, enough of that. Lada, you can play the video.
God was carrying you. You were determined not to leave me where I was. You were intentional about my victory. Wanted me to know what it means to not have to settle. And when they asked me how, oh, I just say, you carry me. Oh, I know you carry me. That's my testimony. I am a witness that you carry me. You were determined to give me an expected end for my shame, Lord.
feels like they need to release. Hold on. You maybe still do, even do. If that's okay. Then also, there's a wonderful that been dealing with and I'm going to say this because I'm also at work. I could barely walk. I said, God, who is? And so as I was but also let's start with the heart. Let's start with the heart. I want you to put under your mind the traumatizing experience that hurts. The person you need to let go, the thing that you cannot shake and it keeps playing over and over in your mind and in your heart. And it's hindering, it's stopping you from serving Him, even being in church. It's time to release it. And when we release it today, it's your responsibility not to pick it back up. Every time it tries to come back up, it's your responsibility to say, let it go at the altar. On this day of October the 5th, 2024, I am delivered. Every hurt, every pain, every arrow, everything that the enemy is trying to use from your childhood, I declare you are released from it now in the name of Jesus. And you will not die before your time. I declare in the name of Jesus that you are healed, set free, and delivered. And you will feel the Holy Spirit's presence as you go throughout this week, as you go throughout the rest of this year, as you go throughout the rest of your life, how He wants to help you live a free life, a stress-free life, an anxiety, even anxiety. If you've been feeling anxiety, you can't talk, catch your breath, or nervousness, I want you to just lift your hand. Can't sleep at night. Woo! Jesus. God, I thank you tonight. God, I thank you for your power. I thank you for this setting. I thank you for the women. I thank you, Lord, in the name of Jesus, God, that your Holy Spirit is resting upon them. I thank you, Lord, oh God, that today they are walking in freedom. I declare in the name of Jesus, Satan, you take your hands off of their bodies, take their hands off of their legs in the name of Jesus. I declare in the name of Jesus, they go. God, I thank you now. Oh God, that they are free, and whom the Son sets free is free indeed. They are free from trauma. They are free from pain. They are free from anxiety. They are free from insomnia. They are free, oh God, from cancer. They are free from diabetes. They are free in the name of Jesus. what he's shown you that you will be doing. Thank you, Lord. Thank you. Have a strong voice to win young ladies. They follow you. They follow you. They listen to you. But when you be the example in the earth, Lord, we thank you now that we are obedient to your direction. We are obedient to your voice. We are obedient to your word. Lord, I thank you now that everything has been hard in the name of Jesus. And she's making it easy for you. In the name of Jesus. He's the God. You're the God that makes everything easy. And so, Father, we thank you now, oh God. Every desperation, God. Every concern, we leave it at the altar today. And we say, God, here, hold this. Hold it for us, God. Put this in your hand and hold it for me, God. And I don't want to get it back from you. Lord, hold this. God, hold this in the name of Jesus. Oh, God, I thank you now for covering her children, covering her mind. He said you are set apart and different. You will not, I hear a family of mental things going, but he said that will not be an effect for you and your head. The name of Jesus. Lord, I thank you now for deliverance, your power, breakthrough. Breakthrough in their finances, breakthrough in their bodies, breakthrough in their children. God, you said, oh God, that you will fight for our children and save them in the name of Jesus. So, Father, we call them in. We call them in. We release that concern to you. And Father, we thank you now. Thank you, Jesus. Thank you, Jesus. Thank you, Jesus. Oh, thank you. For keeping us. Thank you for keeping us. Thank you for, do you belong, you go to the church? Come here, come stand by me. You're one of the ones that was me before I was describing myself before my breast. There's some stuff that you got to let go. Some people you got to forgive. But you got to do it quick. And I'm not trying to plant fear. I'm not trying to make you do anything. But this is an instruction. Do we always have to go to the people and say, hey, forgive me? No, you don't, but you need to do it anyway. But if it'll make it better, he said, I am calling you out. You have a strong guard on this heart, a strong stone on this heart, because guess what? You've been disappointed so many times. You've been rejected so many times, and you're trying to protect yourself. But this is one thing I remember that the Lord told me. You couldn't even protect yourself if you wanted to. Somebody still going, something you can walk outside and fall and you'll still hurt yourself. So you can't protect yourself even if. But God loves you. He loves you. And I can hear your voice and God, just trying, God, trying. I'm trying, y'all. I'm trying. Can't do this by yourself. I mean, you've been hurt. You got it probably every right to feel how you. Don't even rehearse it. Don't even get on the phone talking about it. Yes, God. Yes, God. Yes, God. Let it go. I don't know. What's your name? I feel like. And the Lord says this. not trying to prolong y'all. And what I love about our Father is that even in the tears, He hears. Come here, baby. I've been watching you. Come to the baby.